Shall we start? Hi, Dr. Ko. Shall we start?
Another minute.
Yeah.
We're gonna start at 3:03 lah.
Hi, very good evening for all panelists and also participants for today. Welcome for our 4th week of Geriatric month. So today we have, today's topic will be Frailty and also Sarcopenia from normal clinical usage to COVID-19 prognostication. Okay, so to chair this our session today, we have Dr. Khor Hui Min. She's a consultant geriatrician from University Malaya Medical Center. We're glad to have her today for today's session. So without further ado, Dr. Khor, we can start our session today.
Thank you very much, Jeevan. Yeah. So today, thank you for joining us at the College of Physicians webinar, the Geriatric series. So we're very glad to have Dr. Low Chung Ming to join us today. So Dr. Low is a consultant geriatrician and internal medicine physician at Loxi Charitable Hospital in Penang. He's also the head of services of the medical unit at where he works. Dr. Low is a certified dementia care skills trainer under the Alzheimer's Disease International. He's also very passionate in teaching and works part-time for the postgraduate diploma in primary care for the elderly under Sunway University. So I've known Dr. Low for quite some time. He is very experienced and I'm sure he's got a lot to share on this topic today. So without further ado, we'd like to invite Dr. Low to share his talk today on frailty and sarcopenia, from normal clinical usage to COVID-19 prognostication. Over to you, Dr. Low.
Thanks, Hui Min. Thank you everyone for joining us today. Good afternoon. Today is the 4th week in our geriatric medicine webinar, and I'm sure if all of you have joined my friends in the previous weeks, you all probably would have learned and seen a lot about geriatric medicine. Although geriatric medicine is not a very common specialty in our country till now, but I'm sure today's topic, all of you are very familiar with frailty. But it's just that maybe a lot of times you all just cannot put your finger to it and put it into words. So let's share today what is frailty. Just some disclaimer. I'm sure a lot of my colleagues in geriatric have been repeating this a lot, but I don't mind sounding like an old recorder to repeat this again. Throughout the whole world, we know the population is aging, and it's no different from Malaysia as well. The lifespan of our country's population is aging, and to illustrate it in the form of population pyramids, you can see the population pyramid for Malaysia looks exactly like a pyramid during independence, but at the turn of the century and as of this year, it looks more like KL Tower. And in 20 years' time, you can see with declining birth rates and longer lifespans, we see a bigger and bigger proportion of middle age and older age in our population, with the younger age group in a smaller proportion. This poses a problem because as a whole, we look at the proportion of the older age group in our country. WHO defines a nation as an aging nation when the elderly population exceeds 7%, and they attain the status of aged nation when the elderly population exceeds 14%. This is worrying for us because if you look at more mature and developed countries, the transition from aging to aged nation took them more time. But for younger developing countries like us, this transition is very quick, and the policies and our healthcare, whether we are keeping up with this change, is quite worrying. Back to frailty, why is it relevant, this aging population? Because as we will see later, age is probably one of the biggest risk factors for frailty, but it's also important to understand that aging does not equal to frailty. in the short definition is that frailty is a condition in which the individual is in a vulnerable state where they have an increased risk of adverse health outcomes when they are exposed to a stressor. It is important to note that frailty by itself is not a disability, or rather not yet a disability, but it is a clinical syndrome of increased vulnerability. Other definitions, more academic-wise, is that it is a clinically recognizable state, which is what we are trying to discuss here today, is that to emphasize for us when we are doing our clinical work to try to recognize it, that this state of increased vulnerability resulting usually from aging and its associated decline in reserve and function across multiple systems, such as that the patient has the impaired ability to cope with everyday or acute stresses. I would again like to repeat and emphasize that increasing age does not equal to declining health. Almost all of us have learned from our physiology class during our undergraduate days about homeostasis. Homeostasis, where our physiologic reserves allow us to adapt to outside stresses and try to revert whatever that has become abnormal to become normal. Now, as we age, there's a term which has come up, which is called homeostasis. In simple terms, is that the ability for us to maintain homeostasis will decline, such as that when a similar stressor which is encountered by a younger person and an older person with homeostasis, the older person tend to decompensate and have adverse health outcomes. Another diagram to illustrate, very simple here, look at the red line as someone who is frail, whereas the green line is someone who is not frail. So both of them encountered the same minor illness, say a UTI. The person who is not frail also encounters or suffers from an impairment in their functional abilities, whereas the one who is frail will suffer much more impairment in the functional abilities. And if you can see the recovery too, those who are not frail tend to be able to recover back to their baseline, whereas those who are frail, unfortunately, even if they recover back to become independent, but they may not recover back to their baseline. Remember, the stressor is still the same for both, right? Again, another graph to illustrate this. We admit and acknowledge that even with normal aging, free of disease, there's still a decline in your organ functions, and with it, your functional capacity and reserve as well. But if there are chronic diseases or you have bad lifestyle habits such as smoking or chronic diseases which are not controlled well, this aging process tends to accelerate. More and more of us are recognizing frailty as a phase just before disability. And this is important because it provides us a window of opportunity to intervene. So if you are able to recognize someone who is frail but not yet disabled, there's a time window for us to try to have interventions to try to either slow down the decline to disability or even reverse them back to the state of independence. The prevalence of frailty has been quite consistent worldwide. This is British data. It's not surprising that the older you get, the prevalence of frailty increase. And it's also well studied that women tend to be more frail than men. Local data, this is fresh out of the oven, just barely a month old, this review of our prevalence data in Malaysia. To be honest, look at the range, seems like a wide range, but it's actually still quite similar to international data, which is around 6 to 10%. The 57% is actually an outlier. The paper actually was a paper on institutionalized adults. And that is why the high incidence of frailty in that population. But more importantly, one of the papers they reviewed, for example, although the frailty prevalence seems low, like 6 to 10%, but look at the pre-frail is as high as 60%. So we're looking at both together, almost 70% of our elderly population are either pre-frail or frail. And the impact of frailty has also been well studied. Frick, who is you can say the father of frailty because he was the one who first proposed it, look at the mortality and survivability of those who are frail. Not surprising again, the mortality increase the more frail you are. Rockwood also, who is also another giant in the frailty, demonstrated not only increased mortality, but also increased institutional care in those who are frail. Now, we've been mentioning Rockwood and Frick, who are actually, you can say, the two fathers of frailty. Frick first and subsequent all the models and all the concepts of frailty, you can say, derive mostly from these two models. Frick first proposed frailty as the phenotype model, where he says that frailty is a syndrome where specific characteristics can be measured and you can categorize people into frail or not. And these characteristics are mainly physical, as you can see, muscle weakness, walking speed, weight loss, reduced activity, and exhaustion, which is self-reported. Rockwood later came up with another model, which is called the cumulative deficit model. And with that, he states that frailty is a state where there's a wide range of potential deficits. And it is not just physical deficits he was measuring. He was measuring also functional impairment, social, as well as psychological deficits. And it is a continuous variable compared to phenotype model. We'll look at it more closely. This is Frick's definition or the phenotype model. You can see there are 5 components to it. It may be more appealing to us clinicians because these are all quite measurable. For weight loss, for example, you ask for unintentional weight loss. Weakness, you measure by measuring the grip strength. Exhaustion and activity levels are measured by questionnaire and self-reported. And gait speed is also measured. So out of these 5, if the patient has 3 criteria, they are classified as frail. But if there are 1 or 2, they are classified as pre-frail. And if they have none of these, they are considered not frail. The challenges with this model is that even if you measured someone and you classify them as frail, there is no indication of which area for them which is the impairment. In other words, it does not offer us an opportunity to institute interventions targeted to these patients. And in a busy medical clinic, looking at this, you need to measure the walking speed, you need to have the space, you need to have the equipment to measure the grip strength. It may be challenging. And for a lot of our older patients who are, say, cognitively impaired or disabled, this may not be such a reliable and useful tool to use. Now, look at Rockwood's model. This is what he called the cumulative deficit model. Seems to be a lot of deficits here for you to measure, but remember that he did not derive this as something which is fixed. So throughout the years, some people have cut it down to 30 deficits, some have even more than 100 deficits for them to calculate. So you just looks like a checklist, you just check what the patient has, and it is reflected as a ratio of how many deficits the patient has. And as I mentioned earlier, this model of Rockwood's, the cumulative deficit model, does not only look at the physical, also look at other aspects or domains like cognition, mood, social, energy expenditure, etc. More and more of us, again, also recognize frailty may not be limited to just the physical dimension as well. It also involves psychological dimension and social dimension and others as well. The challenges to this model, again, it is not so easy to do. You need to sit down, ask a detailed history. A lot of times you may even need to do a full comprehensive assessment before you can really come down and see what type of deficits this patient has and say he's frail or not. And it's because there is no fixed cutoff value for this, it is perhaps not so appealing to us clinicians because where do you say this patient is frail or not? As such, it is actually a continuous variable. But it's not to say that one is better than the other. In fact, these two models are equally useful, but probably in different settings. Looking at the contrast between these two models, you can see clearly that frailty phenotype like the Frick model concentrates solely on the signs and symptoms, or rather the physical signs and symptoms. Whereas Frailty index is broader, it encompasses diseases, ADLs, functional, etc. Frailty phenotype, you can straight away do it even by your nurse outside before he walks into your clinic. Whereas Frailty index is more time consuming. You probably need to sit down, talk to the patient for at least half an hour before you can come to a conclusion. Phenotype, as I mentioned, there's a cutoff, so the variable is categorical, whereas Frailty index is a continuous variable. Frailty phenotype has a predefined set of criteria, whereas the index can expand from more than 100 deficits to less. Is up to you. And Frailty in the Frick model, remember, if you have 1 or 2 out of 5, you can define it as pre-frail, and if 3 or more, is defined as frail. And they understand that, and they define frail as such as a pre-phase before the person goes into disability. Whereas Frailty index is just a model saying that you accumulate deficit. Remember that in the cumulative deficit model, functional impairment can also be one of the deficits. So a patient can already be disabled when calculating the cumulative deficit model. Whereas in the Frailty phenotype model, the person is deemed not yet disabled when you're measuring it. And that is also why if you try to measure the Frailty phenotype in a disabled person, you may face some problems. Whereas for Frailty index, you can almost measure it for everyone irrespective of their functional status. But looking at this, you must be thinking, you must be crazy to ask me to do all this in a busy clinic, isn't it? And yes, Rockwood recognized that. So he finally came up with another model. If you look at the first 2 models, at the phenotype model, the cumulative deficit model, this, he called it as something based on clinical judgment. And in terms of practicality, it's probably the most practical one. We can look at detail. The CSCF or Clinical Frailty Scale is a spectrum from a very robust, very fit individual up to terminally ill. A score of 1 to 9 can tell you how the patient is. You can even picture it. We can look in detail. So 1 who is someone very robust, still exercise regularly. 2, when patient has no disease or symptoms but is not as fit as 1, still exercise occasionally. I think most of us fit there. 3 will be you have a medical problem, say you have some diabetes, high blood pressure, but it's well controlled, but you don't do much exercise. 4 is your disease give you some symptoms already, and these symptoms limit your activities. So common complaint, they'll be saying, I'm just tired, I'm just, oh, I can't do this, I can't do that, right? 5 is when they're starting to be mildly frail, they're already slowing, and higher order of ADLs, what we call instrumental activities of daily living, such as transport, finance, they will be needing assistance already. And when they are 6, moderately frail, they will need help with anything that has to do with out of the house activities or even keeping their house in order. A lot of times, even they may need a bit of assistance with their basic activities of daily living. Whereas 7, you're fully dependent on ADL, and when you're 8, you're very severely frail, you're completely dependent, and some of them may be approaching the end of life. And 9 is for people who have life expectancy of less than 6 months. So I believe after looking at this, I hope in your mind you'll be thinking, yeah, I can do this, because I mean, how long would you take? You probably just need to ask a few questions on what do you do, what can you do at home, how are you, and how's your disease control, things like that. Probably wouldn't take you more than 15 minutes or even less to do this, right? And to make it even easier, there's an official app that you can download to your phone and just through the phone and do this. So there's a questionnaire. You just click yes, no for the questions, and it will give you a score. So the wonders of technology, isn't it? Of course, there are many other assessment tools, ranging from if you want to do a detailed measurement or screening tools, but you can say almost all of these tools are actually derivation from the first 2 models, which is the phenotype and the cumulative deficit model. Personally, I still feel the clinical frailty scale is the most practical in the sense for our busy day-to-day clinical practice. Now, the hypothesis of why frailty occurs has not been really proven, but it is hypothesized that it is an interplay between disease trigger and also the inflammatory and response to these diseases and other environmental factors. So as a result of this, you get dysregulation of the stress response system and increase in certain inflammatory markers. Clinical consequences will be anorexia, sarcopenia, osteopenia, impaired immunity, cognitive impairment, reduced clotting, and disturbance in your glucose metabolism. And this brings you to the final clinical frailty syndrome of slowness, weakness, weight loss, low activity, and fatigue. Exactly what was measured by Frick, right? Frick, this is what Frick put out in his original paper, where this vicious cycle of, again, interplay between reduced total energy expenditure, chronic undernutrition, weight loss, sarcopenia, and reduced strength comes into play and results in the geriatric giants, which I hope some of you all know, such as immobility, falls, etc. And that brings us to the next topic, which I think we cannot leave out when we discuss about frailty, which is sarcopenia. And sarcopenia is defined as an age-related decline in skeletal muscle mass as well as muscle function. And to measure it, or rather based on definition, we measure it by proving that patient has a low muscle mass, and muscle strength, and also or low physical performance. And the impact of sarcopenia, again, not surprising, it causes reduced physical capability, impacts your quality of life, impact cardiopulmonary performance, and even increase your mortality. For measurement of various of the muscle mass, strength, and physical performance, in research, they have used many different methods to do it, but for practical purposes, in clinical practice for muscle mass, for example, bioimpedance analysis and DEXA scan probably is the one which is most practical to use. Bioimpedance analysis is something just like a weighing machine where you can, or some of you who goes to the gym, you may have seen it before, where they measure your level of fat, level of muscle, etc. DEXA scan is the same one you are doing for your osteoporosis, for example. Muscle strength, most of the studies have been using the dynamometer, which I've shown here, where you ask the patient to grip and you can measure the grip strength, whereas physical performance can be done with a series of short tests, such as short physical performance battery, or just a simple get up and go and usual gait speed. The problem with this is that when you measure sarcopenia and you take the cutoff points, the Caucasians and Asians, obviously, you cannot take the same cutoff points that has been used in the West and used on our own population. So back in 2014, I can say the experts in frailty and sarcopenia in our region came together and they formed this working group, Asian working group for sarcopenia. And despite the heterogeneity of our population, Asia is huge, isn't it? They are bigger, stronger ethnicity in the north, maybe, and smaller size of us, maybe in Southeast Asia, for example. But despite that, they're still able to come up with a cutoff points for muscle mass, muscle strength. Physical performance is still used the same as what have been used in Europe. So, and together during that meeting, what they have suggested in how you screen for sarcopenia is, first, you can do a quick screen on the strength and the gait speed. And if that is low, only you proceed to muscle mass measurement. And if that is low too, only you can diagnose as sarcopenia, right? Now, why do we need to measure frailty and what we can do for it? Unfortunate to say, evidence has been quite patchy here and there for the interventions. People have tried other things like even hormone, vitamin D supplementation, which have some small evidence in proven patients who are proven with low levels of vitamin D. But otherwise, I guess the interventions with the most evidence will be physical activity and incorporating some resistance exercise in it. But first of all, we need to remember again, frailty is a spectrum. So from the robust to the terminally frail patient, the interventions obviously will be quite different. So when the patient is still fit and robust, the focus should be more on relieving any acute symptom that they have, goals, advanced care planning, and setting the goal with them and making sure the family and carer is around to support them. As they grow frailer and frailer, interventions can come in form of incorporating an exercise for them, ensuring adequate nutrition, getting a comprehensive assessment done. GEM stands for Geriatric Evaluation and Management. It is a specialized unit to manage usually acute patients, acute admissions of geriatric patients. And the ACE and PACE are also programs actually in the US where, in other words, they incorporate a full range of medical and social services for older persons. So as you get older, you may need more and more of these social services. And finally, terminally ill patients, you may think of more of hospice and comfort and dignity. You are thinking of less aggressive screening. You're thinking of the concept of less is more. You are trying to refrain from unnecessary procedures or hospitalizations. So you can see that the focus shifts a lot if the patient is on different ends of the spectrum of frailty. Okay, so I hope I'm able to at least explain a bit on what frailty is, because next we're going to be looking at how frailty has been used in clinical practice. Now, COVID-19 has ravaged us since last year, and a lot of research has been done in a lot of areas for COVID-19. No different for frailty as well. Lots of papers have come out, and I think during the awful circumstances in Italy, and at one time maybe some parts of our local areas, and I believe now in Klang Valley also, you have that unenviable job of having to choose patients which to live in the ward to basically die, and which patients will get the ICU bed and ventilator, for example. So probably consider frailty as a better measurement rather than a direct cutoff of age to determine all these resource allocation. Because as geriatricians, and I'm sure you all as clinicians have seen that no two 80-year-olds or no two 60-year-olds are quite the same. So probably frailty is a better surrogate for prognostication rather than age. As proven in this paper, each 1 point increase, remember the CSF has 1 to 9 points, was associated with a 12% increase in mortality. And this association is linear. So it is possibly you may want, in these dire circumstances, using CSF as a better cutoff to determine, sad as it is, right? What about in other specialties as well? In cardiovascular disease, again, not surprising, cardiologists have recognized that frail patients have much more complications from medical treatment as well as other interventions as well. So it is a strong independent predictor also in heart failure patients for emergency department visits and hospitalizations. So you may have to rethink the benefits of your cardiac interventions in a lot of the frail elderly patients, whether the benefits outweigh the risks or not. And even the Heart Failure Association of Europe, they have actually come up with their own frailty model of their own, because they recognize that the prevalence of frailty is especially high in patients with heart failure, and they can see that it is a strong and independent predictor of negative outcomes. So this is their own model, but it's not really been validated yet, but you can see that they have recognized the importance of frailty. What about in renal patients? Again, not surprising, those end-stage renal failure patients on long-term dialysis, prevalence of frailty has been reported to be as high as more than 60%. And this frailty is independently linked with adverse clinical outcomes, not just in end-stage renal failure patients, but in even the early stages of chronic kidney disease. So what is the recommendation here is that if you are able to recognize frailty, you should do a holistic assessment to your patient. For example, incorporating individualized exercise programs, ensuring adequate nutrition intake. These are the few interventions you can think of, and also for goal setting of care plans in the future for patients and their carers, right? End-stage renal failure per se by itself, the uremic situation per se itself is already a pro-inflammatory condition. And by interacting with, remember the hypothesis for frailty as, again, dysregulation of the stress response system of our body, this again constitutes a vicious cycle, and uremia and frailty basically don't really play well together. It worsens the patient much more, right? So the recommendation is that do a holistic assessment, which includes treating any symptomatic conditions, review the medication. Polypharmacy, again, is a risk factor for frailty, prevention of fall if there are fall risks, and goal setting and advanced care planning. Ensure adequate nutrition, managing the complications of chronic kidney disease, exercise programs, and always discuss with the patient regarding any treatment decisions for that matter, not just renal replacement therapy, right? What about in the ED? I think all of us have been seeing patients in ED during your on-call days, and it has been proven again, if there is the difference between a standard care and keeping in mind frailty when you see an emergency patient, right? When you have frailty in mind and you look at the patient in front of you, you understand that you need to look at other dimensions before rushing and coming to a premature closure. You will look at the health, not just the health problems, but the social problems as well. The nurses will perform assessment on the patient's function 2 weeks before the current presentation, and they will enable you to discuss better with the family on what interventions to do next. And a lot of advanced events happen in the ED itself. For example, drugs, invasive procedures, etc. So by recognizing frailty, it can constitute like a warning sign for you and institute all these preventive measures early. A lot of times we are all, as physicians also, we have been called to assess patients preoperatively, right? And to see whether they are fit to go for surgery or not. Unfortunately, although it's well recognized that frailty increases the risk of adverse outcomes in patients going for surgery, but there's still lack of evidence whether any interventions can be used effectively for patients preoperatively. So, for example, a few of these papers may have used different methods to measure frailty, and successfully they have predicted different adverse outcomes for patients who are going for surgery. But also there have been suggestions, for example, to have targeted interventions. For example, if you have seen patients with a history of falls and maybe some Parkinsonian syndromes, then you may need to preemptive advice and may have to start anti-Parkinsonian medication early, look for non-motor symptoms of Parkinson to avoid things such as constipation, delirium, for example, or patients who have exertional dyspnea but not picked up or not diagnosed yet prior COPD or heart failure, you may be able, if the surgery is not urgent, for example, you may want to ask the patient to stop smoking first, get his vaccination complete, especially now in this situation, and pulmonary rehabilitation to start, right? Other geriatric symptoms, for example, falls, you may want to institute anti-osteoporotic measures, treatment, supplement with calcium and vitamin D, manage the fall risk, prehabilitation, which is rehabilitation or physical therapy before the surgery, right? If they have cognitive impairment, you know the risk of delirium is higher, you may need to institute delirium prevention measures in your ward, right? So Look, a lot of things can be done if you really look into it. So frailty is quite wide, but again, when we are able to recognize at which part or which domain is the most frail part of the weakest link of that patient, and we can institute preventive measures, by that it is hope we are able to reduce the adverse outcomes. But more importantly also, by recognizing frailty as a marker of adverse outcomes, I think we're better placed to discuss with the family or the patient themselves the benefits versus the risk of going in for an intervention, right? So in summary, I hope I'm able to share with you that frailty is just a state of vulnerability to stresses. Frailty measurement tools are many, but they are all largely based on the phenotype model or the cumulative deficit model. And if possible, frailty should always be assessed for any reversible causes. And frailty, hopefully, rather than age alone, probably this is the take-home message I want to say today, is that do not use age alone as a measure for prognostication, but rather try to use frailty as a prognostication marker for adverse outcome risk in older adults, right? Okay, thank you.
Thank you very much, Chung for the very insightful talk. I just want to remind the attendees, so if you have any questions, you can either put it at the chat box or the Q&A box for Dr. Low. So maybe I'll start the ball rolling and I'll start off with the first question. So Chung, you did mention about the CSF and the different CFS scale for frailty. So maybe my question is frailty reversible? So for example, if someone is CFS 7, can they become CFS 6? You know, is there something like that? Because sometimes, you know, when you write something on the notes, right, this patient is CSF 7, you know, it will always be stuck to them forever and ever. Is there a thing that they can be reversed, or whatever management that we give, is it something just to slow down the progression of the frailty?
Yeah, so I think one of the participants asked the same questions as well. So almost all guidelines have recommended to screen for reversible causes of frailty. I think as physicians, most of us know what reversible causes we are talking about. It can be a vitamin deficiency, most of the time maybe B12 or D, it can be anemia, these or hypothyroidism, for example. This we know is easily treatable, but unfortunately, of course, there will be causes of frailty such as late advanced stage malignancy, for example, which may not so easily be reversible. So I guess it depends on what frailty is so wide, from social to physical to psychological. So if you catch a depression early and you're able to treat it, theoretically you should be able to reverse that frailty. But unfortunately, if it is, say, a neurodegenerative disease such as late-stage Parkinson's or advanced Alzheimer's or terminal malignancy, I guess we have to be practical enough to recognize, yes, it may not be reversible, but again, the whole purpose of recognizing frailty is to recognize that and institute the most sensible measure in the best interest of the patient. And best interest a lot of time doesn't mean reversing them to their previous functional capability, but rather the best comfort or care that we can provide at that time.
Excellent. Thank you very much. So I think there is a question from Dr. Ho. So I think there is this big hoo-ha about, you know, using a frailty scale, the CFS scale, in determining, you know, like what you mentioned, who gets the ICU bed, you know, or should a patient be intubated or not. I think the question is that, is there any specific training to administer the CFS? Or, you know, is there any guidance or any certificate that you get to say that, you know, you are okay or you're able to accurately administer CFS?
I may not be answering this correctly because, to my knowledge, I don't think there's any formal training course for it. But now, even if they've come up with an app, I think anyone who has downloaded the app are able to answer the yes/no questions. So I think the beauty of CSF is its simplicity itself. So if you really need training to administer it, then I guess it probably defeats the purpose. But I guess the important thing to remember here is that when you ask, it's supposed to be 2 weeks at least before the current presentation, and not when they're already sick. And when you ask, obviously they'll be very frail, and you may just put them in the ward or in the no ventilator list.
Yeah, they're all CFS 8 when they come in, because they're all in bed and not being able to do anything. Yeah, I guess it's very important just to highlight that it is what the patient can do 2 weeks before they became unwell. So I think that gives us a better measurement of the CSF. Is that, I mean, you did mention also, you know, there's so many disciplines nowadays that can use CSF to actually predict adverse outcomes, whether is it surgery or whether is it to go for dialysis. Is there a specific age cutoff where they can use the CSF?
I think the whole point of incorporating frailty is hopefully we can take off age as a marker for prognostication, isn't it? I mean, if we use it correctly, then age should be irrelevant, if I dare say. Right. So yeah. So I guess no, age is not one criteria we use, hopefully.
Okay. Okay. So I do have patients as well. You know, they will always be asking, doctor, is there anything that I can take to make me feel stronger? So those patients who may have, like, you know, sarcopenia, weak muscles, I mean, what would your advice be?
I mean, I'm sure a lot of you all get the same questions as well. They'll show you some supplements they buy from some now even Lazada and Shopee. Just yesterday, I had someone show me from Lazada some supplements. Well, I mean, the correct answer, the professional formal answer is that to date, I don't think there's any evidence to show any supplements work in that sense. But obviously, nutrition is important. So my advice to patients is always, I mean, usually the pills they show you will be multivitamins or minerals. So if you are able to get it from your normal day-to-day food intake, I would always advise that to be better rather than supplementing it. Of course, like I mentioned briefly just now, if they have proven low levels of vitamin D, there's small recommendation to supplement it as one of the measures to intervene for frailty. But otherwise, if there's no measurable deficiencies in any minerals, I don't think we should encourage or support patients to take supplements.
Do we, I mean, this is just practice. Do you normally measure the older person's vitamin D level?
That's a good question. So you understand when we were in government setting, probably there was a bit, because of the resources and all, probably not much, but I think I will be probably doing that more now.
I think there was also some evidence, especially in nursing home residents, especially true that it seems that vitamin D does help in those patient setting as well, I suppose. Okay. So we're still waiting for other question. It will make me ask all the question then.
I think this topic is a bit vague. I mean, even when I first got in touch with this topic, it seems like a very vague and not so easy to grasp topic, isn't it? I mean, it's not something we are used to. We can measure, say, LDL is above this cutoff, below this cutoff. It's something we see day to day, but it's just not so measurable to us. And
there's no like specific biomarker, you know, to test and see how frail you are and what degree of frailty you are. Because I think it's just encompasses so many domains of a person, right? So I think it's just hard to specifically say you're frail because of this and this. So usually a lot of multifactorial thing happening.
And also most difficult, I think, is until now also there is no consensus on which measurement tool is the best. So everyone is using their own, and it's a bit difficult. That's why hopefully with more and more research, we are able to come to a gold standard tool, and then from there on, they're able to extrapolate more data on, say, the risk of certain adverse outcomes, then we are able to better counsel our patient based on that.
Yeah, I think maybe I'll just ask one last question. You know, there is, with the vaccination drive going on at the moment, on the guidelines, it did say, you know, that if your patient may be at CFS 8 or above, then you may consider not vaccinating them. I mean, what are your thoughts about it? I mean, are there any population of patients, older patients specifically, that you feel, no need to vaccinate also can lah?
I joined the forum by Dr. Richard and Dr. Riza on that, and I agree with them totally. And the consensus that was that unless patient is actively dying, then otherwise all patients should receive the COVID vaccine. For me, what I feel is that we must understand that in getting infected with COVID is probably also a suffering, I mean, compared to, say, some side effects you may expect from the vaccine. So yes, I think vaccines should be incorporated, should be given to everyone except those who are actively dying. Exactly asked about polypharmacy. I think that's a good question. Again, there have been good evidence even from the British guidelines on frailty that medication reviews should be one of the intervention for frailty. So we know that a lot of our older patients are on so many medications, and a lot of them not the doctor's fault, because the doctors does not know what the other doctor has prescribed, and they've been seeing so many doctors because of there are so many different diseases. So what happens is that if nobody sits down and just look through all their medication, they may be taking a lot of redundant medicines, or some medication may be prescribed from years ago and they are not necessary now. So without looking through that, so it's sometimes impossible to pick up all this. So yes, what was the question again? Sorry, how is it supposed to be done? Is it, what can we do? So I guess what can you do is at every opportunity you get to see an older patient, be it in the clinic, in the ED, during acute admission, upon their discharge, take it as an opportunity to review all the medication, reconcile them, what we call the process as medication reconciliation, meaning take away those which are unnecessary and give them what is necessary, and try to change drugs with more adverse outcomes to the ones with the least side effects, for example, and medications try to cut down to the least effective dose. So these are the ways you do medication reconciliation at every opportunity. I guess that's the answer.
Have you had difficulties trying to get the older person to stop medication that they've been taking for the last 20 years?
I think you see both extremes, right? There are older persons who just so reluctant and resistant to start any medication, and even if you start, they may go back, keep it for a few months, then only take it as they like. And then you have some patients who just love their medication, and the more you give them, the better. So it really depends on what type of mentality that older person have. But yes, you have encountered that. So a lot of times you may have to do it slow. For example, asking them to try cutting it down first, see how they feel. They're okay, cut it down some more, something like that.
Okay, we've got also one question. This is about the nutritional product, the HMB, to help build muscles. So would you say this is a valid recommendation? Would you get your patients to take, oral nutritional supplement with HMB product in it?
This sample. Apparently this is a new project they showed me, which usually is in the milk, right? And this they come out with a product which is in sort of like citrus drink type. So I mean, I've seen the papers. I would say it sounds convincing, but I probably is not that well trained to critically appraise a paper. So I would say yes, especially if they are not taking enough protein in their usual nutrition intake. But remember that just by eating, you don't expect to build a gym body also, right? you need to eat well and to exercise well as well. And of course, other aspects like controlling your chronic disease and could do away with your bad lifestyle habits. So everything has to come together. It's not just about eating something and expecting the muscle to grow.
Yeah. So I think it's a combination of like what you've mentioned, resistant exercise and also taking adequate diet. I mean, it will be a bonus if they can, have some HNB or, increase the protein in their diet that will help the muscles grow, isn't it?
Yeah.
Okay. Okay. Thank you very much. I think we haven't got any more questions. So maybe I'll just get Dr. Loh to leave us with some take-home message. If there was one or two things that we can change in our clinical practice, what would that be? What would you want to impart us with your pearls?
I think as I repeated many times, and I'm sure my fellow geriatricians have been fighting this in the system a lot of times, is that do not use age alone as a surrogate for prognostication. So in other words, do not be ageist, do not discriminate solely based on age. So here I would like to promote probably frailty as a better way of prognosticating your patients rather than just using purely age as a cutoff and playing God by ourselves. I mean, all of us don't like to play God, but a lot of times we may need to. So probably frail may make you a more just God, maybe.
Yeah. Okay. Okay, thank you. I think all this will have to be imparted even to our junior colleagues to ensure that, when you present a case, don't always say this 92-year-old elderly man or woman, probably, hide that off to actually make sure that we don't become ageist when we see our patients. Okay, thank you very much, Dr. Loh. It has been a good 50 minutes time with you, and we thank you for sharing with us about all the insight on frailty and sarcopenia. And we can see that how this concept is going to grow within other disciplines as well, and we'll sure come across with this concept one and again. Thank you very much.
Thank you.
Thanks.
Hi, thanks a lot for Dr. Loh for the great session for today. So thanks for all the participants who attended this week webinar. So we're having see you next week for our last week of geriatric webinar. It'll be a confused patient. So by then, see you then. Thanks.
Thank you. Bye.
Thank you. Make sure we don't get confused. Thanks.